De qual céu mais você vem?
Kanellopoulos from my center here in Athens, Greece, clinical professor of ophthalmology at NYU Medical School, New York City, New York, and medical director here at the Laser Vision Ambulatory Surgery Center in Athens, Greece. I was asked, and I'm sorry I couldn't be there in person, with my friend Pedro Grimaldos for putting together this excellent meeting. I was asked to put together a few slides on custom ablations, and I'll share some of the course that I give both at the American Academy. This is a slide from this year's Academy meeting in Orlando. The ESCRS, we gave this course in Copenhagen in September, and the ASCRS last year and this year, hopefully this coming year in 26 in Washington, D.C. So we're going to go look at a few things on the status of customized ablations today. I do consult for a lot of companies that are involved with custom ablations, mainly Alcon, Zeiss, and Bausch & Lomb. And let's go look at the next slide. And here are, again, my financial disclosures. The middle QR code, the green one, is a QR code that you may want to take because it has all the videos, the technique videos, the clinical example videos that we have in our YouTube channel, the Laser Vision YouTube channel. And the right QR code, the black and white one, is our custom ablation group, which is a forum that we can post interesting cases, discuss them, etc., etc. So you're welcome to visit the YouTube channel on the green QR code, and of course the custom ablation forum for further discussion. So key thing in custom ablations is to have a good understanding on what each individual cornea imaging gives. Placido distal imaging is not the same as Seinfeld imaging that we're seeing in pentacams, not the same as OCT imaging, and we have a great tutorial, refractive cornea imaging principles at YouTube that would recommend you to follow. I work with this every year with our senior residents at NYU in New York, especially those who are interested in going through refractive surgery, and I would encourage you to take advantage of this 1-hour tutorial on and I'll explain to you why. This was a medical legal case I had the privilege of consulting on in Manhattan, New York. And this case had LASIK and had poor vision, and everybody's diagnosis was ectasia. And when we first look at this picture after LASIK, we would say, yes, this looks like keratoconus. But if we look at the 4 images on the pentacam, we can see that although there's inferior steepening in the sagittal curvature pictures on the top left, also mirrored at the elevation maps on the top right, if we look on the bottom right, which is the posterior cornea elevation, it's normal. And then if we look on the thickness map, the thinnest part of the cornea is not the most curved part of the cornea. So this is not an ectasia case, this is a mixed astigmatic case treated eccentrically because the patient was probably closing their eyes during the procedure. The laser could still see a pupil, but it was decentered and the ablation was placed inferiorly in the cornea, as we can see here. So these 2 slides showcase how important cornea imaging is. And of course, we reported one of the first in the world on using topography guided in improving visual outcomes. This was back in the Journal of Refractive Surgery in 2005. Then you can see here enlarging optical zone on the left, on the top treating keratoconus, on the bottom, middle, treating a scar from contact lens infection. And we've reported extensively on this in the past over 50. Here we will see the presentation that we did on using custom ablations in Orlando. And we made the same presentation also in the ECRS in Copenhagen, and how we can treat cornea scars. And all these that we'll see here are mainly from contact lens infections that leave irregular corneas that are incapacitated, especially in patients who cannot wear contact lenses, and how we can. Here we will see the presentation that we did on using custom ablations in Orlando, and we made the same presentation also in the ECRS in Copenhagen, and how we can treat cornea scars. And all these that we'll see here are mainly from contact lens infections that leave irregular corneas that are incapacitated, especially in patients who cannot wear contact lenses, and how we can use, for example, in this particular case, a very customized ablation, see here in the top right, that will treat the irregularity caused by a cornea scar. And you guessed it right, the scar, if we look at the zero refraction ablation on the top right, is right at the area that the laser does not want to treat, the green area. The area around it is the area that, by the flattening that the scar causes, behaves more steep. So the laser can read that on reflection topography and will treat that irregularity and normalize the cornea along with the refractive error, which is added in the treatment plan that you can see on the bottom right, which has the top right picture and the refractive error at the same time. And we can see improvement in cornea scars. This is the scar that we saw before, drastically improved. And again, you can see the before and after OCT anterior segment comparisons on the bottom left. And again, how the scar has been normalized and reduced significantly. It hasn't disappeared, but this patient is able to function with better than 20/30 vision now. Now, going in keratoconus, I would draw your attention to the Journal of Cornea. Editorial was asked by the Journal of Cornea, put together all of the knowledge we've had the last 20 years in treating keratoconus with a combined custom ablation and accelerated CXL, cornea cross-linking. And I worked in this editorial of putting together all the investigators throughout the world that have used the combination treatment. And basically all the results are similar with our Athens protocol signature treatment, where we combine, as you can see on the top right, a hyperopic type ablation along with a myopic ablation to regularize in regular cornea. And you can see from that paper, and again, this is Journal of Cornea, October of 2023, we can see the before, after in the middle, and difference map on the far right, and see how drastically the cornea is normalized with the Athens protocol CXL. We can see on the anterior segment OCT images on the bottom left that the CXL line is very deep and very uniform. And we're going back to regular eyes and how in a regular eye, as we see here, sometimes we have the oxymoron that our refraction that we can see on the top is half a diopter at 45 degrees, where if we treated this eye with topography guided, and we can all agree that this is a strictly with a real astigmatic eye, the topographer wants to correct one diopter of astigmatism at 0 degrees, completely different axis. And this is why we speculate and we reported this regular astigmatism acts for the patient irregularly because there's significant angle kappa. The angle kappa is circled on the top left picture as the pupil decentration of the vertex versus the center of the cornea. And on the y-axis, it's 200 microns. So this cornea is used by the patient eccentrically, so this regular astigmatism acts as an eccentric prism. So the patient has to pick some arbitrary astigmatism to neutralize that prism. That's why a manifest refraction is different than the topographic salinity. If we do a Weffer-optimized treatment on this, noise in, noise out makes no difference. You can go ahead. But if we perform a topography-guided treatment on this cornea, the topography device will, by default, normalize the cornea to the vertex and will do the correction we're seeing here on the far right. Thus, the astigmatic error of that eye will change, and we have to correct that. Another example here, again, see the refraction is only half a diopter at 160 degrees, where the topographic cylinder, and you can see the placido disc images on the bottom here, is minus 125 at 18 degrees. Again, if we do a topography guided treatment, the topography is going to reshape the cornea, which is not an irregular cornea, but due to angle kappa, the regular oblique astigmatism of this patient acts as a prism and makes the patient pick an arbitrary cylinder to neutralize this prismatic effect. We reported this as and named it topography modified refraction, an approach where we use when we do topography guided, we use the topographic amount of cylinder and the topographic axis, and of course, usually it's more, so we add astigmatism, we go with the topographic axis, and we remove the spherical equivalent of the added cylindrical correction from the spherical equivalent of the patient. And we showed that if we randomize eyes, one eye we do with a manifest subjective refraction, the other eye we do with this TMR technique, we got far superior result. This is a paper from 2015, And you can see here that the TMR eyes outperformed the non-TMR eyes, even if we went 50% on the TMR axis and 50% of the TMR difference. Now, ray tracing that we discussed in a separate presentation is a technique that I've had the privilege of working first in Europe since 2019, first in its automated version. It's now named Wavelight Plus by Alcon, and it really underlines the correction and the pathway we used with TMR. All this work that we described before is done automatically by ray tracing. And this is published data, our first paper in 2020 in clinical ophthalmology, our first experience with ray tracing to customize ablation. This is an international multi-center study that had the privilege to be the medical monitor from Germany, another center in Germany, Greece, and Australia. And the results were outstanding. This is also part of the published literature. This is our own study looking at 2 years and looking at the 6 key question at the National Eye Institute Visual Function Questionnaire and see how well these eyes performed. So ray tracing is really a procedure to stay for as a standard of the best possible customization and treatment. And we'll see more and more on that. And it did prove the concept of our TMR in the past. And we've used ray tracing, and I'll use it here in our examples, to treat some very irregular corneas, such as the 51-year-old post-LASIK ectasia pilot that we treated with ray tracing. We were able to normalize the cornea. And we can see here the post-op results. We can see the pre-op on the top and the post-op at the bottom. You can see the drastic improvement in this cornea ectasia pilot and how he ended up improving his contrastivity and improving his coma. Of course, this is off-label using ray tracing. And of course, we published using ray tracing in keratoconus as well. This is in the Journal of Cornea in 2021, and how ray tracing can help us in that aspect as well. So in conclusion, we're seeing several aspects of a customized approach to use regular, our naive myopic eyes that we treat every day, and some complicated eyes such as cornea scar, keratoconus, and previous problems with refractive surgery. And we're seeing that ray tracing may be a way to solve this. We've proven that topography guided with TMR is a definite way to prove this. And again, in those patients that are intolerant to contact lens or cannot function with contact lenses. John Kanellopoulos from Athens, Greece, signing off. Thanks so much for your attention. And just closing the Athens protocol crossroads. We've done a lot of work with this. This is the treatment that we suggest. And again, the steps of the Athens protocol, the topography guided treatment, the PTK, the CXL, summarized here, and some results pre, in the middle, postoperative, and the difference underlying the significant normalization. You can see this cornea in the difference map has flattened in the cone area by over 10 diopters and has steepened in the superior flattened area, sunken area, I should say, by almost 7 diopters. So we have a normalization almost close to 18 diopters with applying the Athens protocol and treating very little refractive error. And again, another result here showing how the topometric data have normalized, and this eye now is able to function regularly. We've published on the psychometric quality of life impact of this treatment in these young adults, and it's part of the published literature. We're hoping that Brillant microscopy may be able to help us diagnose those early cases, but for now, for cornea diagnosis, we rely on cornea imaging, family history. If there's a family member with keratoconus, every teenager in the family has to be scanned. Special attention to youngsters with atopy, vernal, eye rubbing. Epithelial mapping is essential, in my opinion, in every eye patient, and keratoconus especially. And we have the vaccine for keratoconus. Let's use it. Let's make the diagnosis early. John Kanellopoulos from Athens, Greece, signing out. Thanks very much for your attention.